Hi, I'm Annie Sleece, and I'm on the staff at NAMI Delaware. Thank you for being a part of this conversation today about substance use, risk, and resources. Before we get our conversation started, I'd like to take a minute just to tell you about our agency in case you haven't heard of us before. So, NAMI Delaware is affiliated with the national organization called NAMI, National Alliance on Mental Illness, which has been in operation for more than 40 years. It is our nation's largest grassroots mental health organization, and it was founded by family members who were seeking support and information navigating the mental health journey for their loved ones, with their loved ones. NAMI Delaware has been around almost as long. We were founded in about 37 years ago, and we work to support, educate, and advocate for individuals and family members affected by mental illness. We do that through programs, support groups, awareness events, trainings, outreach. We have a helpline, and we also have a housing program. So we have a lot of opportunities to get connected to information and support for you, for your loved ones and friends, and for your community. Since the pandemic began, we moved our programs to an online platform. So we're offering things like this Facebook Live conversation, and we're also doing our support groups and other online programming using platforms like Zoom or like Facebook Live. So before we start, I do want to tell you about one event coming up that we wouldn't want you to miss. May 30th is our virtual walk. Every year we have a walk in May, and it's our biggest fundraising event. We use this opportunity to raise awareness and funds to do the work that we do. This year, our walk will look a little different. It will be virtual, and we want you to take part. So please check out our website, namidelaware.org, and find out how you can be a part of our walk. Now, before I invite our guests, I do want to say one more thing, and that is this conversation is meant to bring you information and support, but it also may generate strong feelings. So we want to make sure you know how to access immediate support if you need it. We want you to know about the crisis text line, which is available 24 hours a day, 7 days a week. You can access it by texting 741-741, and this will provide you immediate response in a crisis. We also can offer you other opportunities to get resources using our website, but we are not a crisis resource ourselves. Therefore, we want to make sure that you know how to reach out to get some support if you need it immediately. Now, our conversation today will be about substance use, risks, and resources, and we have two wonderful guests that I'm very happy to have with us. First, we have the Executive Director of PACE Inc. His name is Bruce Johnson, so welcome, Bruce. And we also have Public Policy Coordinator of Attack Addiction and a founding board member, Dave Humes. Hi, Bruce. Hi, Dave.
Hello.
Would you all like to introduce yourselves or share anything else about you that you'd like people to hear?
Dave, go ahead. You go first.
Attack Addiction, we are a nonprofit. We're all volunteer organization. We've never had a paid employee. Everything we do is to try to help people who are going through addiction issues. We sort of think of ourselves as little Dutch boys and Dutch girls, and when we see holes in the dike, we go and plug some thumbs and fingers in there to try and get these people some help. And we do a lot legislatively, wherever we can help to fill these holes.
Great. And we also know that you are a naloxone trainer. So we do have a banner up right now sharing that information. And I'm sure you can share a little bit more about that in a little while, Dave.
Yep.
How about you, Bruce? What would you like to share?
Well, I'm the Executive Director of PACE. I've been the director since 1994. PACE has been around for over 30 years. We are a substance abuse program where we run primarily IOP programs. We were probably the first independent IOP in the state of Delaware. And we also run a partial hospital program. So we're really focused on just substance abuse, running groups, running programs. We do evaluations, we do referrals. We connect with a lot of doctors in the community for medication-assisted treatment, if that's for somebody for alcohol or opiates, or if they have any type of dual diagnosis, co-occurring disorder, mental health disorder. We try and get them to psychiatrists that can help them. So we do a lot of referrals along with that.
Wonderful. Can you, for those of us who don't know, what's IOP stand for, Bruce?
Good question. Yes, got to quit the vernacular. IOP is an intensive outpatient program, and typically that's an after-work program. So people might come 6 to 9 or 10 to 1, 3 times a week. Typically, people drink more than one time a week. So the concept of I'm not knocking this, but an individual therapy once a week for an hour sometimes just isn't enough. And for the clients that are struggling a little bit more, a partial hospital program or a PAP, sometimes known as day treatment, that runs from about 9 to 3:30. And that's 6 days a week. Now, currently, we're doing telehealth. We will do an evaluation in person, but everything's telehealth, so the schedule's a little adjusted. So we are open. It's a challenging time for everybody, including us, and we're addressing it and making some good changes.
Great. Well, thank you. So before we kick this off, I do want to welcome everyone who's tuning in right now. And if you have any questions for us as we have this conversation, feel free to pop those into our into the comments, and we will address those either as we go or at the end before we conclude today. So we want to thank everybody who's tuning in live. So let's start with some numbers, Dave. As one of the founding board members of Attack Addiction, I'm sure you're very attuned to the data around Delaware and addiction. Can you share a little bit of that with us?
We have, for several years now, we have been calling this the public health crisis of the 21st century. It's we have to give it more gravitas, if you will. As we sit here today, the official count is that we've lost 135 Delawareans. We've probably lost more than that because it's very typical that by the time they get results back from the forensics division, that may take 30 to 60 days. So it's probably actually higher. Part of it's—
Is that this year? Is that what you mean?
This year, as we sit here today, at 135. Yeah. But when we look at what's happening in Delaware, unfortunately, we are first in the nation in per capita prescribing of high dosage, long lasting opioids. So that's a position we've held for several years, and that's not a position we want to have the state be in. No. We are now second in the nation in per capita overdose deaths in 2018. We lose about 43 people for every 100,000 people in the States. We're up from tied for 5th in a 1-year time period. We've had an 18% increase in these statistics. We are 5th in the nation for the rate of children affected by parents or loved ones that have addiction issues. So these categories are places we don't want to be. We don't want to be in the same categories as people in West Virginia and Kentucky and Ohio and Pennsylvania. So despite everything we've been doing so far, we still have to do more, and we have to have a greater sense of urgency. We had 431 overdose deaths in 2019 in Delaware. While nationally, the number of overdose deaths has actually gone down by a slight 4%. Our overdose deaths have been going up in most years, double digits. So this is a continuing problem here. And we can look at the actual cost in dollars to the state. I have 3 figures I'll throw out. One of the figures is $100 million, and that comes from former Attorney General Matt Denn in a study he did. When we hear Director Romero of DSAM speak, she says that the cost to the state is approximately $80,000 per each overdose death, which brings us to a total of $320 million. But if you go by the Surgeon General's first ever report on opioids, he says the cost to the nation is $400 billion. So if you prorate Delaware on population, the cost of Delaware alone is $1.15 billion. So whichever figure you choose, it's just traumatic It really is.
Hmm.
But,
Definitely,
it's
definitely.
costing effort, but the human cost
Right.
obviously can't be
Hmm.
so.
Sure. And all that data you're sharing is all pre-pandemic, right? This
Yeah.
is all information that has been gathered before the COVID-19
Yeah.
crisis has begun. And certainly we know, just from what's going on with people responding to COVID, that people are in elevated emotional states, right? They're seeking ways to cope, and substance use may be one of those ways that they're coping. So
Absolutely.
so yeah, so let's move into ways that we as members of the community, as Delawareans, as family members, can be identifying these warning signs of someone who might need help, and whether people are viewing right now looking for help for themselves or looking for help for a loved one or just wanting to know in general. Bruce, as a treatment provider, can you help us with those warning signs and what we might be looking for?
Yeah, that you can get a lot of fancy language and use DSM-5 and all the other stuff, but the
Hmm.
phrase I always like to use when I'm talking to family members or clients is
Hmm.
the term unmanageability. Does your drinking or drugging create a problem somewhere or somehow in your life? And the reason I like that definition so much is it doesn't really talk about how much you're drinking or what your drug you're doing or what you're or how you're doing it. It talks about, or how often you're doing it. It talks about how it impacts your life.
Hmm.
So a client can come to us or a
Hmm.
family member can come to us and say, give 500 reasons why they're not an alcoholic or a drug addict because they've had 500 times where they used alcohol or drugs and it wasn't a problem. But when there starts to be issues
Hmm.
with family members complaining or not picking up family members, at prescribed times, or they're missing work, or missing payments, or getting a DUI or some type of legal issue. So you're looking at the categories. Is there a problem with family? Is there a problem legally? Is there a problem medically? We have clients that come in that have cirrhosis of the liver and will say they don't
Hmm.
have a drinking problem. Are they
Yeah.
having with social friends? Is there work issues? So we're looking in those categories for where it's a problem. Do they
Right.
drink so much that it's that they can't remember? Do they sell their parents' jewelry or family members' jewelry to buy the drugs? So we're looking for all those things, and I think if we focus on that element, it becomes very simple to make a diagnosis. So, for example, if I get one DUI, the statistics are that 80% of people who get one DUI develop some form of alcohol or substance use disorder. If it's two DUIs, it's 99%.
Wow.
And at the present time, it's 26% of adults 18 of older say they have a history of binge drinking, and that's right about the population of 15 to 20% of people who have alcohol and drug problem. And I think it's real important we keep talking about alcohol. I know opiates is in the news, and that's rightfully so. But alcohol is a huge problem, and we need to, continue to do that. And if you look at the numbers, the alcohol deaths are still higher than opiate deaths, although the opiates are catching up really, really fast. So not just,
Right.
but we need to talk about alcohol as well. This is a substance use disorder, and
Right.
opiates is definitely ringing the bell at this point in time, and the attention on it is necessary. So
Right. And substances, whether they're legal or not, when
yes,
they're used inappropriately, right?
yes,
That's what we're talking about. We're
yeah,
talking
THC,
about when,
yeah,
right.
yeah.
Hmm.
Medical marijuana, Xanax,
Right.
prescribed opiates, alcohols, all those things. Yes.
So really, as a family member or as a person thinking about myself, it's about the impact that it's having,
Yes.
right? It's about that
Yes.
negative impact. Okay, well that's helpful. That's very helpful. Um, so let's lean into that a little bit more. And thinking as a family member, I can certainly say that my perception before learning more about this work was that when people didn't admit or didn't seek help, it was because they were in denial, right?
Yeah.
Or they just didn't want to or something. And it might even evoke anger in someone who's watching
Yeah.
their loved one get sick.
Yeah.
But I know a little bit more now, and I do understand a little bit more. But can you talk to that about a little bit? Denial, the idea of it.
Yeah, sure. Most people have the vision of addiction is the skid row bum, or the
Hmm.
person who's mainlining whatever. And that's just late stage. There's an early, middle, and late stage of the addiction process.
Hmm.
People don't, smoke their first joint and then, mainline opiates for, the next day. It takes a long time. Same thing
Hmm.
with alcohol. So denial is a way that clients. It's a defense mechanism, like we all have defenses, and we
Right.
use it to our advantage. Father Martin who's one of the pioneers of the field, used to always say that a spouse would confront somebody with an alcohol or drug problem, and the substance use person would say, "I drink because you're my problem," and the spouse would end up going to therapy. And that's how powerful and
Right.
effective the alcoholic or drug addict was. So I think it's real important that we don't kind of get caught up in what rationale or how they're denying. It's a defense mechanism, and understand that they don't want to admit it. And there's lots of defense denial. There's minimizing, rationalizing, intellectualizing. It's blaming others, blaming self. There's the alcoholic who come in and say, "I'm a problem," but it just doesn't have the ability to deal with it. They don't have the skills yet. And that's a form of denial. That's a form of defense. So what I like to talk about with this, and I'll try and make this quick, is the stage of change, which came out in the 90s, which has been a really big part of our field. And what it does is it talks about various stages of change. It's pre-contemplation, which is basically, I don't have a problem, get off my back, which is a form of denial. Then there's contemplation, which is, yeah, I might have a problem, but it's not as bad as anybody else, so get off my back. Or I have a right to drink it, or smoke drugs, or do drugs, whatever. It's, I'm prescribed pills, whatever rationale they might have. And then there's preparation stage, which is, okay, I have a problem, I'm just not quite sure how to get there. And sometimes PTSD comes in the way here. Sometimes co-occurring disorders come in here. Sometimes being a children of an alcoholic come in here. All these are like, this is where the therapy really begins. And then there's the action stage where they're really jumping. And that's what our philosophy is that, we get paid to say the stuff we do. So clients don't really like to listen to us a lot of times.
Right.
And if you get a group of other people who develop some time, 2 or 3, 4 months, they'll listen to those clients, because it's one person who's gone through this process, and it's one alcoholic or drug addict helping another. And that's how that seems to work, in my humble opinion, the best. And that kind of is the best way to shoot through a denial. Family members helping other family members, usually as much as well-intentioned, it's difficult. But and it's hard, and it's painful for the family members. And what I always tell family members is you have to make a decision how you want to live with this alcoholic, if they're active or if they're not. And that's a whole nother piece that I won't go into. So.
Sure. But well, I'm going to give a shout out to Wesley, who's behind the scenes right now, helping us navigate this conversation. He's posted the Stages of Change website into our comments, so that anyone who wants to seek that out, they can do that. So Bruce, as you mentioned, the family members, that's an important piece. And also you talked about people who've been through this, maybe counseling others or talking through with someone who might be experiencing addiction early on. That lived experience piece is helpful. I find that really interesting, especially in the work that NAMI Delaware does around mental health conditions, because we have kind of the same philosophy.
Exactly.
We have peers helping people who have lived experience, who've been through the experience and are on the other side of it. And then we also have family members who have supported someone experiencing something like this, and they want to help other family members. So I feel like there's so much connection here that I'm so grateful that you're having this conversation with us. So on the topic of family members, let's hop over to Dave here, and let's talk a little bit about your experience, Dave, and what you might identify as barriers, either through the work you do with attack addiction or your own personal experience.
Now, when it comes to barriers, the first thing that comes to mind is when you're first touched with finding out about this, when you don't know about something, where do you go to find out what you don't know? If you're sick, you know what to do. You call you pick up the phone and call the doctor. If you have a toothache, you call the dentist. If you have a legal problem, you call a lawyer. But when you're first getting into somebody in your loved one who has addiction issues, you really don't know where to turn.
Sure.
Where we are right now today, it has touched so many people. It's not even six separations anymore here in Delaware, 2 or 3. So people are starting to find out about organizations like NAMI, because we know addiction issues are co-occurring with mental health issues, and they're reaching out
often,
right. They're reaching out to organizations like PACE, who does a lot of family counseling and whatnot, and they're hearing about attack addiction, so they have an earlier starting point. One of the other things that brings me into this is I'm a person in long-term recovery, and I'm in recovery from a lot of things I've I've never had opioid addiction. And I don't say that because it would embarrass me to say so. I say that because I don't understand the nature of opioid addiction, because I think it's a
Mhm.
far greater addiction than some of the other.
Yes.
Mhm.
And when we talk about my personal experiences, I had a son with addiction issues,
Mhm.
and I thought I knew how to deal with them, but his addiction issues were heroin issues.
Mhm.
And we know all these illegal drugs, they take good kids to bad places. They took my son to prison. He did 2 stints there. After a second stint, he really got serious about trying to take care of himself, and he was doing everything right in his life. And as he was gradually reacclimating, he was getting together with some old friends, but he bumped into some of his old running mates.
Mhm.
And he went off with them, and he thought he could do this one more time. And as a result, he overdosed. And the people he was with, they lifted him up, they put him in his car, they drove him to the hospital, and they didn't honk the horn on the car and run like the Dickens. They didn't go to the emergency room door and hit the red panic button there, and they didn't go
Mhm.
run a block away and get on the phone and say, "Go look in your lot." And by the time he was found, it was too late. Um, so some of the barriers are, though, even though you think you may know about what some of these issues are, you can't understand it unless you've been there. But you can
Mhm.
offer your help by constantly being there, and letting that person that you love so much know that you love them
Mhm.
and you accept them where they are, to try to get them to realize and go into treatment. There was a lot of optimism I had along the way. At one point, my son Greg said to me, he said, I'm tired of this. I don't want to spend the rest of my life in institutions, whether they're correctional facilities or rehabilitation facilities. And that's when he really got serious. But it just takes one slip. We look at somebody like Philip Seymour Hoffman, who had been sober
Yeah.
for 20 some years and
Mhm.
relapsed and overdosed and died. So, the thing is, we keep saying it, you're not alone, but you have to find that person to talk to, so you're not alone. And the sooner
Right.
you can reach out, there are so many people that are out there willing to help you and talk to you and help you see your way through it, and
Mhm.
their experiences to them. That's what you really need. You need a peer.
Yeah. Thank you, Dave, for sharing that journey that you share. And I've heard you share that story before, and each time it just wells up so much emotion in me as a loved one myself. But nothing can take away that loss that you've experienced. Yet you are putting so much of your energy and your pain into this important work to help so many others, and we're just so very grateful for you and your story
Yeah.
and the work that Attack Addiction is doing.
It's
Thank you
and
so
again,
much.
I have to say, it's not just me. We have many parents at Attack
Right.
Addiction
Mhm.
Mhm.
who have experienced those losses and who have
Mhm.
been willing to be the face. And as we are
Right.
the face, it's going to help us break down the perception of who a person with addiction issues is.
Right, right, right. And family members oftentimes don't know where to go. They
Right.
don't know what to do. They do feel alone. And you and I have spoken on this many times, Dave, as I've shared with you my personal journey too. And as family members, we want to support others now, right? And we're putting ourselves out there to make people understand that there are ways to get help, ways to support one another, and ways to support people who are struggling with addiction.
Yeah.
And the work that you're both doing is so incredibly important. Thank you very much.
There's just an awful lot of irony in this too, because when I started to embrace sobriety, it was because
Mhm.
3-month-old and a 14-month-old, my 2 sons, they saved
Sure,
my life. Literally, they saved my life. And the irony
sure,
of that
sure.
fact is, I couldn't save my sons. And we have a member of Attack Addiction, Liz Waters. I can't tell you how active she has been,
Mhm.
both Attack Addiction and Hero Help. And she had a
Mhm.
son in long-term addiction, and unfortunately, she just lost him last week.
Oh,
So
I'm
again,
so sorry.
another irony. of this disease
Right.
and how serious it is.
Right. This disease is just tragic. It's tragic. And what we're doing today and what we continue to do in the work that all of us does is really just try to get ahead of it and try to make people aware of the resources available and the treatment options, which is actually my next question. I really want to give people some very tangible ideas about ways to go with either conversations with loved ones or themselves. What kinds of treatment options are out there? I know we've touched on a few, but Bruce, could you maybe go into that a little bit before we wind things down, and maybe take some questions from any viewers that we have?
Yeah, sure. ASAM is American Society of Addiction Medicine. Make sure I get that right. And they came out late 80s, early 90s. And back in the 80s, it was only an inpatient modality. That's all they had, 28 days. And back at that point in time, Dave and I are both old enough to remember this. It was crack cocaine was the big drug, and it was having the same impact that opiates has, but it didn't have the dependency on it. And that's when Dave was talking, that's the problem with opiates and crack. It does so much damage to the brain, much different than what alcohol and marijuana does, and makes it so difficult for clients to stay sober. But they were all going to inpatient for 3-4 times a year at $28, and Chrysler and GM was paying for it and locally, and so people got upset. So they started to create levels of care. So there are basically 5 levels of care, and this is what programs like ours use to decide what level of care. So it's just not willy-nilly. We're making decisions based off much of DSM-5 and ASAM. So there's an outpatient level of care, which is basically individual therapy, which is a great place to start. For clients, and we talked about denial. If they're in denial, they're contemplation, they're just not ready for full commitment. But get them on that ASAM level of care. Get them in something so they can start to look at it and work on it. It sure beats staying at home and all the other stuff. So individual is a great way to start. If they continue to use or it escalates, they may then get ready for a higher level of care. The key is getting them somewhere on that level of care. The second level is the IOP, which we talked about earlier, the program we run, which is kind of an after work program. Then there's the partial hospital program, which is all day. And then there's the inpatient level of care. And there's a couple levels. There's detox, where you can be there for 5 or 6 days, depending on the drug. Some drugs can last longer, or alcohol. And then there's a residential, which could be anywhere from, 2 weeks to, 45, 50 days. And it's all supposed to be determined by these dimensions. And I think I sent you guys the ASAM. I don't know if we did or not, but I can certainly send that to you. But the dimensions are based on what we're looking for. As far as, I got to turn my page to make sure I get all these, we determine what specifically we're working on. So we're assessing. The first dimension is risk of withdrawal. So somebody who has a crack cocaine, have a problem with crack cocaine use disorder, there's no withdrawal there. It's just the marijuana. There's very little withdrawal. So that wouldn't be a high risk for somebody for inpatient if we're just using that dimension. The second dimension is biomedical. Are there any heart issues? Are there any liver issues? Are there any seizures issues? Are there any issues that might make the withdrawal from this particular drug more damaging? So we want to get them in a safe environment. So that's why when we're doing assessments, we ask a lot of medical questions. Then there's the emotional behavioral. Are there PTSD issues? Are there co-occurring depression? Are there bipolar? What are the risks there for them being able to need for inpatient versus can they stabilize in these higher levels of care? And some of these are black and white, some of these are gray. And when we're talking to insurance companies, sometimes we have disagreements with it, or talking to family members. And that's fine, because it's not a black and white thing. And then the other phrases are, sorry, I'm 61, my memory's bad.
Oh, you're fine. You're doing great.
And resistance. So where's their treatment? Do they want to be there? Now, insurance companies don't really like, they're not motivated. We can say, yeah, they need to be inpatient because they're not motivated. Some insurance companies don't like that. But where's that? If they're really motivated, then maybe they can make it at a program like an IOP or PHP. If they're not motivated, which is fine, that's part of there usually is always some form of external motivation that brings people to our office. We've never had a client come into our office really excited to be seeing us.
Sure.
And then there's what is the risk for relapse? Do they have a history of relapse? So for people that have opiate addiction or have, crack cocaine, those are very, very high risk for relapse. People who may be drinking beer on a daily basis, they may not have the risk of withdrawal maybe, but they're going to be high risk for withdrawal. Living alone. One of the things we're seeing now is that people are at home and they would have a 5 o'clock cocktail or whatever else other thing, and then that led to 4 because nobody was around, and then 12, and then 2, and now
Then it's
12.
noon.
Now
Yeah,
it's
sure.
been 2 months, and now we're seeing a lot of calls from people in full-fledged need for inpatient, and they just don't
Okay.
want to go because they have the
Okay.
work issue. And it's been and then the last dimension, I'm sorry, I'm going through these quick, is the recovery environment. And this is the most important. And this is what Dave does. Dave's program, Attack Addiction, does so well, having these sober houses out there. Because if we can get them to an inpatient, or if we can't get them into an inpatient, and we can stabilize them in our PHP, then we can refer him to some of the sober houses that Dave has, or the Lyman House. And that's really important, to have people in these new environments, because if you get them sober and then they go back to that environment, which is of drug use or alcohol use, they're going to relapse. Typically, it's very hard to stay sober. So getting them in that new environment where they have the support that Dave talked about, where they have, maybe kind of almost like a family there, work through that helps them stay sober long term. I can't encourage these sober houses, and that's something that Delaware's done really well, particularly Attack Addiction.
That's great. Yes, thank you. And thank you for mentioning those houses. I don't think we shared that earlier about Attack Addiction, but that's an incredible part of the work that you're doing. And the recovery piece is just critical, as you mentioned. You also mentioned that when people do either attend a house like that or in some sort of recovery setting, it needs to be like a family. And that's important. And what about, let's go back to the families. What could we be doing as family members if we're seeing our loved one through this walk? What could we be doing on the sidelines to help them, to support them? Are there resources for us? Dave, maybe you could speak to that.
Well, I always like to steal a good quote, and one quote I like is, "Trust the whispers in your head." So when you think, if somebody's in recovery, you think that they might be slipping or whatever, you have to trust those instincts, to make sure you talk to them. You have to
Sure.
keep the conversation open. You have to continue to speak with them. You have to continue to support them. I had some rough times with my son. I told him,
Sure.
you dial the numbers. I will always answer the phone. I constantly told him that I loved him, and I told him that he deserved a better life than the life he was living. So, but I do want to mention a couple things. We touched on it earlier. One of the things that people really need to know, we've had a 911 Good Samaritan Law here in the state since it's 2013. When we passed it, it was one of the best laws in the nation. It still is.
And you helped that start, didn't you? You helped make that law a reality.
Yes.
Sorry, I didn't mean to interrupt, but I wanted to give you credit where credit is due.
But that law has been in effect since 2013, and it's one of the best laws, even as we're here today, because it grants immunity to arrest, charge, and prosecution. When you talk with the community who was in use when we put this law together, and you talked about those people in early recovery, we said, why wouldn't you call 911? And they gave us some of the reasons. The biggest fear was arrest, because if they get arrested and spend a night or two in jail, even if they don't get charged or prosecuted, they're liable to lose jobs. There's a whole lot of that can happen to them. So that's really important. But the people that even know about the law don't even know about the second part of the law, is it applies to underage drinking. And we need to continue to get that word out about the 911 Good Samaritan Law. Again, I want to talk about naloxone. It's critical, particularly right now. If you have somebody that has been in use, may still be in use, you need to have naloxone, on your possession, just in the event that they do relapse and they do overdose. We are continuing to do our naloxone training. We're doing it virtually. What we do is we try and get a group together to do it, and once we do the virtual training, I make arrangements. I personally go out and I'll meet one person who then will redistribute the naloxone so we can get it out in people's hands. So it's important to get it out there now. So if there's people with community groups out there that are listening and you need training, feel free to contact me and we'll set something up.
That's wonderful. Thank you. Thank you. Now, I did notice a couple of really encouraging comments I wanted to address, and just thank you all who are watching A lot of people just checking in, saying they're watching. Hello, thank you. One of our viewers said, this is such a good topic, especially right now. I feel like a lot of people are drinking way more than normal just out of boredom. So, I mean, this is a really critical time to have these conversations. And now during Mental Health Awareness Month, obviously, we need to be addressing anything that's connected to mental health awareness, and substance use is absolutely connected. We have another viewer saying, thank you, very good information. I also wanted to direct everyone's attention to the comments where thankfully Wesley behind the scenes has been posting lots and lots of helpful links. He did find the American Society of Addiction Medicine, what Bruce mentioned earlier. He's posted that website here. We also have Attack Addictions resources as well as helpishere.de.org. All really important state opportunities to help individuals and family members who might be struggling with addiction right now. I just want to open it up to anyone who's viewing might have a question. And if there are no questions, we can certainly wrap things up. And if Bruce or Dave, if you have any concluding thoughts or comments you'd like to share before we finish, I'd love to invite you to do that.
Well, I always feel that there's some people we have to talk about. Marie Allen in the state of Delaware has been out and talking to schools since the late 1990s when she lost her daughter. She's a Delaware hero. She really is.
Mm-hmm.
She was doing this when she was the lone voice in the wilderness. And we have to acknowledge Jeannie and Don Keister starting Attack
Mm-hmm.
Addiction less than 2 months after they lost their son, Tyler. And
That's
it
right.
wasn't started as a support organization. It was started as an action organization. And, those people that really
That's
led
right.
the way, it's important that we mention them. On the helpishere.de.com site, also, you can contact for people who are first finding out they have somebody in use. There's the Partnership for Drug-Free Kids, where you can call in or text in, and you can have peer counseling one-on-one with people who have been in your shoes. So it's another resource that's out there.
Mm-hmm.
And the one
Thank
other
you.
thing we've done recently too is between DSAM, Partnership for Drug-Free Kids, they've partnered with Google. So when you do searches
Mm-hmm.
for addiction issues here in Delaware, it sort of brings them all up to the front now too. So these are some things we're doing to make some improvements. And again, we have the Behavioral Health Consortium here in Delaware,
Mm-hmm.
well, that addresses both of those issues. That's open to the public. Come find out
That's right.
more about those issues.
That's right. That's right. Thank you. Thank you. And Bruce, did you have any concluding thoughts or comments?
I think there's a couple things, when we're talking about families, some of the phrases that go out is that, you can't control people's drug use and you didn't cause it, but you can have an influence on it, and you can, change it at some level and change how you're living with that situation. And you should never give up, like Dave was talking about.
That's right.
When I talk to family members, I always talk about there's two types of things that impact a family member, and that's influence and leverage. And influence is, I love you. Can you get well? Can you get well? And influence doesn't really help a lot. It's necessary. It's constant. You always have to do it. And the family members will look at you and they will make promises, but the call of the drug sometimes is just too powerful.
Right.
Leverage is more powerful, and it creates, and it doesn't always work, but it creates motivation for clients. When clients come to see us, there's always some leverage. It's a doctor saying they have to see him. It's a psychiatrist saying, I'm not giving that prescription to you anymore. It's a workplace. It's a family member saying, if you don't do this, I'm leaving, or you can't see your grandkids anymore. It's all these things that are causing them to come in. And then over a period of time through the process, which is multiple, they start to work through that denial and work through those stages of change and hopefully get well. Not all of them, but it's that leverage that gets them where they need to be. And we can all look at our own personal lives where we were told to do something and people say you should do it, and it was influence. And it wasn't until something really bad happened, like my own root canal, that I started flossing every day, so
I got it.
It's kind of the reality of life. It's we'll get it tomorrow, but until you feel that pain, you don't do those behaviors. So it's a kind of a human nature thing. So that would be the piece I would say to family members is don't get frustrated, don't give up, never give up. But understand that you have a choice of how you want to live with this person and how you are going to be. And sometimes leverage will get them where they need, and sometimes it doesn't. So that would be my 2 cents.
Thank you. I would suspect that it's similar in content to the comments we make with regard to family members of individuals with mental illness. When we hear from family members who are so angry or frustrated, they just don't know why so-and-so doesn't continue with their treatment, they get angry at the person. And we always try to say, try to be angry at the illness, but not the person, right? So it's kind of the same thing, it sounds like just to kind of allow for that leverage to help guide the person and continue that ongoing love no matter what. We can be as frustrated as we need to be, but we need to direct that frustration to the illness or to the condition versus the person. Would you agree with that? Yeah.
100%. And I think when you're and to take addiction in a little different, if you're angry at me, we're not focusing on the addiction. We're focusing on your anger, and that's exactly where I want you. If I'm dealing with denial, I can handle that. So
I can manage
there's
it.
all these magic windows, mirrors, and clients, and so and anger is not going to solve anything except So what Dave was talking about, love them and just love them unconditionally. But the choice is, how do I want to live with them in this situation? Is that as an angry person, or is that as somebody who is going to set boundaries, or is that as somebody that, and everybody's different. Everybody has different situations. But I think that point, yelling and screaming, that's exactly what somebody with a substance abuse problem can handle. Because it takes it off the addiction, which they can't really argue.
Got it. That's very helpful. Very helpful. Well, this conversation has been wonderful. Thank you so much for spending time with us to share this important information. And hopefully those of us who've been checking out this video, whether it's live or later, can use this information that you've shared to reach out and help either themselves or someone else. And the comments certainly include links that are helpful, and anything more that Dave or Bruce would like to share, we can always add into this video later. So please maintain your great work that you're doing. Thank you so much. And please stay in touch with us. We're so proud to have you in our state doing the work that you're doing.
And
thanks everyone for tuning in. Have a great day, everybody.
Thanks, Annie.
Bye-bye.
Thank you.
Dave, you're much better looking.